Hi, good evening. Thank you for this last rapid fire session. I'm Dr. Martin Sunza. I'm here with Fernando Muñoz. We're from Chile. We're going to present the first work from Ruth Lopez Gonzalez from Spain. Welcome. She's going to present us optimizing liver fibrosis screening in metabolic bariatric surgery, a simple and effective approach.
Okay. Good afternoon, everyone. Thank you for being here. I'm Ruth Lopez Gonzalez from Barcelona, Spain, and I'm going to show you our latest study about liver fibrosis screening. I have nothing to disclose. So, as we know, non-alcoholic fatty liver disease is the most common cause of chronic liver disease, about 25% of cases. It's the second cause of hepatocarcinoma and the third cause of cirrhosis on the US. So, the good news about this disease is that it's reversible. So, lifestyle change, diet, physical activity, and so bariatric surgery remains the treatment for the resolution of non-alcoholic fatty liver disease. So we ask ourselves which method can help us to get a good screening before the surgery, but the less invasive method that don't give more timing to do the surgery and just use it for staging. So we perform a single center retrospective observational. We include a total of 239 patients. All of them underwent bariatric surgery. Most of them were female with a mean age of 48. The mean BMI was 42.9, and the most frequent comorbidities we found were hypertension, dyslipidemia, and diabetes. When we ask the patients for the alcohol consumption, about 30% of the patients answer that sometimes they drink alcohol, but not in alcohol abuse. And it's important to say that in our center, it's not mandatory to perform an abdominal ultrasound prior to bariatric surgery. So we decided to test 3 scores: the FIB-4, the APRI, and the liver risk score. These scores are very, very simple, and they are only based on baseline characteristics on the patient and on a simple blood test about liver function. So they are very easy to calculate, and they can guide us before the surgery to see if we have to make more tests to investigate if the patient is affected by non-fatty liver disease. So we found that most of our patients were on low risk on the 3 scores, and after calculate the sensibility and the specificity of each score,
we have.
Yeah, thank you. We found that the most useful tool seems to be the FIB-4, but modifying the parameter. We have to consider up to 1.3. Ergo, intermediate risk and high risk patients must to be more investigated, and we have to make more tests before the surgery to detect this hepatopathy in the patient before deciding the final surgery. Thank you.
Thank you, doctor. I have a question. Why don't you use the ultrasound as a screening in all the patients?
Because in our center, it's you have some late to have the ultrasound, and we have less time to do the surgery, so it's not necessary.
Thank you. I questions from the audience. From the audience. No? Thank you. Thank you so much.
Okay. Thank you.
Okay, our next presenter, Ernesto Fava Semanduras from Mexico. He's going to present effect of metabolic bariatric surgery on liver function in Latin America, a systematic review.
just wait till the timer goes out, or do I start now? Because the timer is already... Okay, here it is. Good afternoon. My name is Ernesto Fava Semanduras, and we have nothing to enclose. NAFLD and NASH are highly prevalent among obese patients undergoing bariatric surgery. However, Latin American data are often scarce and methodologically heterogeneous. We conducted a systematic review to evaluate liver disease among Latin American undergoing bariatric surgery and evaluate post-operative hepatic outcomes. We conducted a systematic review according to PRISMA 2020 guidelines and uploaded our protocol to Prospero. A total of 8 studies were included with a total of 616 patients, the majority from Brazil. The predominant surgical technique was Roux-en-Y gastric bypass with a total of 72.73% and sleeve gastrectomy with a total of 1%. The data analyzed were transaminases, FIB4, NAFLD fibrosis score, and steatosis grade. On the limitations, our diagnostic criteria was heterogeneous. 37.5% relied on liver biopsy, 37.5% on ultrasound, and the resting 25% on serum markers. This variability limits comparability across studies, so that's why additionally there was a geographical bias and a low study quality with levels with 2 to 4 there were present. On the results, we found that 53 to 100% of people had NAFLD, and of those patients had NASH as well. 48% of them had NASH. On the post-operative normalization of ASAT and ALT, defined as less than 30 units per liter, there was a founding of 0 to 85% of normalization, depending on the study. On the post-operative steatosis improvement, there was an improvement in 75% of the patients, primarily from moderate to mild or even absent steatosis. On the NAFLD fibrosis score, there was improved significantly after RYGB with a p-value of less than 0.0001, and also there was this improvement was blunted thanks to weight regain. So that's why weight regain is linked towards fibrosis score with a p-value of 0.015 after RYGB. Also, iron overload markers such as ferritin and iron, serum iron is elevated in steatosis cases. In conclusion, BMS improves liver functions and reduces steatosis and fibrosis in Latin America, and there is a need for standardized prospective multicenter studies in Latin America cohorts, and iron metabolism and long-term weight maintenance may influence hepatic outcomes post-BMS. And that's it for us.
Thank you, Dr. Fava. How many studies did you find outside of Brazil?
Outside Brazil, there were 6 for Brazil and 2 for Latin America in general. So that's the geographical bias. So
yeah, because in your results, you showed that only 1% of the procedures were sleeve gastrectomy.
Yeah, because on the rest of them, they didn't mention the technique used, the surgical technique used.
Ah, okay.
Yeah, that's why 72.73% of them used the RYGB, and the only 1% the sleeve gastrectomy, but the other ones didn't mention them.
Right. In Brazil, the most...
I searched for it, and in Brazil, there is a standardized method for even educational purposes and for the bariatric system, the Roux-en-Y gastrectomy.
Yeah, the most performed procedure is the Roux-en-Y gastric bypass. Okay. Any questions from the audience? No? Okay. Thank you so much.
Thank you.
Dr. Fava.
We're going to continue with Luis Ocaña Guilemi from Spain with the work entitled Association between low muscle mass and metabolic dysfunction associated steatotic liver disease, MASLD, severity in patients with severe obesity.
Thank you very much. I appreciate your presentation. We are talking about how to know our patient before surgery, and we used to use anytime BNI and other standard reason to know our patient before surgery and to decide what kind of operation we're going to do. I think this is not correct right now because we need to make another study previous to know our patient better. I have nothing to disclose. And the obesity and sarcopenia are conditions frequently associated with metabolic alterations such as MASLD. This study, we are going to analyze the relation between skeletal muscle mass, SMM levels, and the severity of MASLD in individuals living with obesity, emphasizing the high prevalence of low muscle mass in this population. So this is our objective, to determine the association between low muscle mass and the severity of MASLD using statistical analysis. This cross-sectional study included 75 individuals classified on SMM, where O is normal muscle mass and 1 is low muscle mass. This is what we are looking for. MASLD was classified into 3 categories, 1, 2, and 3, based on clinical data. A contingency table was used to analyze the distribution of MASLD and across the muscle groups, and Fisher-Stack test was applied to assess statistical significance. The results of the 75 participants, 100% was with obesity, so BMI higher than 30, and sarcopenia risk. Low muscle mass was observed in a big amount of the population, 7.8%, demonstrating its high prevalence. One surprise we had when we make this study is the low rate of sarcopenia, just 4.5 of participants. If you define sarcopenia by ESPEN and EASO, for us it was a very big surprise. While dynapenia, you know, when you are moving your hand, is so low, 4.5%. In other hand, high fat mass was enormous, was present in 92% of the patients, indicating a predominant adiposity profile. When we make another 2 tests, the profile of 30-second chair stand test, we told to the patient to put the hands here in the shoulder and to sit down in a chair during 30 seconds. And the other test we do is 5 stand to sit test, is how long the patient used to do these 5 movements. For this patient living with obesity, is a very hard exercise. And you can see the only patient who obtained the results in the first test is just 3%, and in the other test is just 1.9%. This is the population we was studying, trying to compare the low muscle mass with the MASLD. The results, finally, among those with low muscle mass, 58.8% had severe MASLD, and just 9.5% with normal muscle mass. This association between low muscle mass and MASLD severity was statistically significant in a test of Fisher-Stack. So in conclusion, low muscle mass is associated with significance with greater severity of muscle-mean individuals living with obesity. This finding highlights the importance to assessing muscle mass to better understand and manage metabolic risk in this population. So it means we need to know something more, not only BMI on a standard analysis in our patient, to know better our patient before and after the surgery. Thank you very much.
Okay, doctor. What do you think is the reason that you found so low sarcopenia in your
We are
patients?
very surprised because we used to move 30%, something like that was my thought previous the test. I was talking with our basic researchers in our endocrinical team, and we don't have a reason, because if you talk to me about, okay, your patient looks like very, very strong but have a big sarcopenia, I thought the same, but when you study and you have data and you have a real study, a serious study, you know the truth. And the truth is just 4.5% of our patients have sarcopenia. So low. If you are talking about a population with an oncological disease, you have a big sarcopenia, bigger than 50%. Colorectal surgery, pancreas cancer, etc. So it's a surprise for us. Okay, maybe looks more healthy, this patient, maybe than I thought previous to surgery, because this population. I need to study more patients. These are just 75.
And what was the average age of your patients?
Okay, I don't have the solid data, but in Malaga, in our hospital in Spain, the date used to be around 40 years old, so they are young. So
maybe that's the reason that they were young.
could be, and we insist so much to run. When we prepare the patient, we see the patient 1 year previous to surgery. So we have a big amount of patients waiting for us. And many years ago, I decided to choose this problem and to put like an advantage. So if I have to wait 1 year to operate my patient, I'm going to try to improve the general state of my patient. So we send a physical activity. So maybe they are changing the fat for muscle. In my opinion, this is so important because maybe their weight is the same, but the distribution between fat and muscle is quite different. Could be the reason. In my opinion, if this is the reason, we are doing the things better. Very thing.
Okay, thank you so much, Dr. There is another question from the audience? No? Okay. Thank you. Okay, so our next presenter is Widaya Jason. His work is short-term weight loss outcomes and preoperative liver histology in metabolic healthy versus unhealthy obesity following metabolic bariatric surgery.
Thank you. My name is Jason. I came from China. So the main story for the reason for this study is that I have nothing to disclose. So I'm going to talk about this thing. Because in China, most of the reimbursement for the bariatric surgery is that either you are very obese, or if you're not obese, you have to have metabolic syndrome. And so far, for the metabolic syndrome definition, we still use the old one. That is, other than the weight and your circumference, then with the blood pressure, with the glucose, and also with the dyslipidemia. But the problem is, some patients may not have all of this. Some patients may only have one, for example, hypertension and obesity, which is not enough to be included in the metabolic syndrome definition. But we know that they may have, like, for example, OSA and NAFLD, MASLD, and everything else. They have it, but currently it's not included in the metabolic syndrome, and it's really have something is disrupting our patient, because this kind of patient may not be reimbursed for the procedure. So we have more patients actually, but I'm only collecting for the pilot study. So we have some patients. I'm making it into two groups. That is with metabolically unhealthy and metabolically healthy. And the definition is using the previous definition for the metabolic syndrome that I use. So as we can see that obviously in the metabolically unhealthy patient, the blood pressure and all that they're metabolically more unhealthy. And obviously we have a little bit difference in the weight and BMI. Now we're looking at the fat distribution and the liver pathology. And we always do liver biopsy intraoperatively because we're able to do that. They sign the consent and all that. And the data for the liver, fatty liver and fibrosis is from the liver pathology. So we can see that the VAT in the patients with metabolic unhealthy is more. I think this is understandable. A patient with metabolically disease they're having more visceral fat. But the thing is, this is what I'm trying to say to the government in China, is that even though they are metabolically healthy, if you're only looking at the blood pressure and the glucose, they're similar in terms of the fatty liver disease, and also with the fibrosis in terms of a percentage, there's not different. So even though they're not categorically in the metabolically unhealthy, they still have other diseases. So this is the perioperative data, and you see there's not a lot of difference, and I think this is not really important. We understand that the total weight loss for the MUO is slightly higher, but you see there's no statistical significance. So the conclusion is that despite a more adverse baseline metabolic profiles, the MUO patients achieve equivalent short-term weight loss. This is not the most important, but this is the second one is the most important, is that they exhibited similar preoperative liver disease compared to the patients with metabolically healthy. This finding suggests that the traditional metabolic health status does not significantly impact short-term weight loss efficacy or the preoperative pathology, though the long-term and the hepatic outcomes, we need more data. Thank you.
Thank you, Doctor, for your presentation. Any question from the audience? No? Okay. Thank you so much, Doctor. So the next presenter is Paula Richbien. Okay. I supposed to speak Deutsch. Okay, so effects of metabolic bariatric surgery on intestinal permeability and MASLD around model.
Thank you very much. Good afternoon, everybody. I'm very happy to quickly present to you our research. I have nothing to disclose. Just as a quick introduction, leaky gut is associated with obesity, and it's also known that MASLD mesh is associated with an increased gut permeability. What is not known until now is the impact of MBS on intestinal permeability, so if there's a change after surgery. For this reason, we developed an animal model, first of all in a pilot study, where we found a high-fat, high-fructose, low-protein diet compared with a folate-free diet, and methotrexate injections to be the best model to induce MASH and fibrosis in rats. And so we performed in the main study 8 weeks of this treatment, followed by either OHEB surgery or sham surgery in our rats, and then after another 8 weeks of the same diet, we did all the research. First of all, we looked at histology, liver histology, intestinal histology, and then we did Assing chamber experiments. Just because Assing chamber is not very well known, here are some pictures. There's a chamber, we put intestinal tissue inside of the chamber, and then you can, on the one hand, measure the tissue resistance, so resistance of the intestine, and up here you can see that we can measure molecules passing from one side of the chamber through the intestine to the other side of the chamber, so you can measure the flux of molecules through the intestine. To our results, we saw that our model was really what we expected. So the weight and the liver weight in our animals was significantly lower after OHEB surgery. This also counts for diabetes. And here you can see the results of the gut permeability. We could show that animals after OHEB surgery had lower permeability. So the resistance of the tissue increased after surgery, and there was less flux of molecules from one side to the other side. And also the gut permeability in animals with MASH was lower than in animals with only MASLD. And also the fibrosis markers were lower in OHEB animals than compared to sham surgery. So in conclusion, we saw a significant improvement of permeability in OHEB rats. We saw that markers for fibrosis after OHEB increased, and we had a higher permeability in rats with MASH compared to only MASLD rats. So what is needed to follow up? We need to do the histological workup of all the rats, and of course we need to verify if this is also true in a human model. We're also already doing this, but we don't have the results. Maybe I can present them next year. Thank you very much.
Okay, so any questions from the audience? Okay, doctor, thank you so much for your presentation.
The next work is from Ireland, women Siva Kumar. The work is entitled The Early Impact of Metabolic Bariatric Surgery on Metabolic Dysfunction Associated Steatotic Liver Disease, MASLD, as assessed by FibroScan.
Good afternoon. My name is Wyman Sivakumar, and firstly I'd like to thank the IFSO panel for the opportunity to present this study, and Mr. Avoyle for supervising the study. So I'm presenting the early impact of bariatric surgery on metabolic dysfunction-associated steatotic liver disease, or MASLD, as assessed by FibroScan. And this study was conducted in the Bon Secours Hospital, Cork, which is the busiest bariatric surgical unit in Ireland. We have nothing to disclose for this study. So MASLD is defined by the European Association for the Study of Obesity as hepatic steatosis identified on liver imaging or biopsy in the presence of at least one cardiometabolic risk factor, and this includes obesity. So it's the commonest cause of chronic liver disease worldwide, rising to a prevalence of up to 90% among adults with obesity. It's important to recognize as it can lead to complications such as liver cirrhosis, hepatocellular carcinoma, and cardiovascular disease. So FibroScan is a non-invasive tool which uses transient elastography to identify and quantify both hepatic steatosis by control attenuation parameter, or CAP, and hepatic fibrosis by liver stiffness measurement, or LSM. So for the study, we defined hepatic steatosis as a CAP of greater than 240 and hepatic fibrosis as an LSM of greater than 7, with advanced fibrosis being an LSM of greater than 12. And this is based on the biopsy-validated meta-analyses consistent with the European guideline recommendations. So we conducted a prospective cohort study on all patients who underwent bariatric surgery between November 2022 and December 2024. So 245 patients underwent surgery in this time frame, and those who had an ultrasound of the liver which was positive for fatty liver were offered preoperative fibroscans 6 months before their bariatric surgery date. And 165 patients opted for this, and of these, 163 met the criteria for MASLD. These patients were then offered fibroscans 6 months post their bariatric surgery date, and 92 opted for these post-op fibroscans. So the mean time to post-op fibroscan was 7 months, and this table demonstrates the statistically significant regression of both hepatic steatosis and fibrosis as early as 7 months post-surgery. So the mean reduction in CAP was 26%, and the mean reduction in LSM was 32%, both giving p-values of less than 0.001. 100% of patients had hepatic steatosis preoperatively, and this dropped to 57% postoperatively. So this gave a 43% normalization rate in the CAP score. In terms of those who had liver fibrosis, 43% had it preoperatively, and this dropped to 9% postoperatively. And this...
Okay, there is a problem with the screen.
We stop the...
Will I continue?
The clock.
Okay,
Yeah.
thank you.
So there was, in terms of liver fibrosis, there was an 80% resolution rate of fibrosis 7 months post-surgery. And interestingly, in the group with severe fibrosis, defined by an LSM of greater than 12, 17% had it preoperatively and 5% had it postoperatively. And this gave a 71% resolution in those at this high risk. So in conclusion, our findings demonstrated a significant regression of both hepatic steatosis and fibrosis in the early months following bariatric surgery. And liver biopsy should be reserved for those few with persistently high CAP and LSM scores on FibroScan at least 6 months postoperatively. Thank you.
Thank you, Doctor, for your presentation. So, and congrats, very good work. So, any questions from the audience? No?
How do you perform the liver biopsy in those patients?
We don't do intraoperative liver biopsies. We were just looking at the FibroScan results of the pre and post-op.
But the biopsy in those patients is a puncture?
No, okay. So you didn't perform any biopsy of?
We perform biopsies in a select few, but we don't have I don't have the data on the ones that biopsy.
Sí, por eso. Thank you.
This is the final presentation. Dr. Dina Marquez from Chile. The paper is remission of MASLD 6 months after metabolic bariatric surgery experienced in a single Chilean center.
Hi everyone. I have nothing to disclose. Our work was about the remission of MASLD 6 months after bariatric metabolic surgery, and we'd like to present our experience. Metabolic dysfunction associated with fatty liver disease, MASLD, is strongly likely to obesity, linked to obesity, Type 2 diabetes and metabolic syndrome with risk of progression to cirrhosis and hepatocellular cancer. Bariatric surgery has shown potential to reverse steatosis and improve metabolic health beyond weight loss. To assess MASLD remission at 6 months post-bariatric surgery in our Chilean cohort using clinical, biochemical, and imaging criteria. We used a retrospective cohort of 84 patients between 2023 and 2024 diagnosed with MASLD by ultrasound plus metabolic criteria, evaluated anthropometrics, metabolic syndrome components, liver function tests, and ultrasonographic findings before and 6 months after surgery. Statistical analysis included pair t-test and logistic regression, and the results of that was that hepatic steatosis resolution was found on 78%, with ALT and ACT significantly reduced by a p% less than 0.05%, and 65% of our patients normalized fasting glucose and lipid profiles with weight loss strongly correlated remission. As conclusion, bariatric surgery led to high MASLD remission rates and significant liver function improvements in this cohort. Further long-term studies are needed to confirm durability and mechanisms of the hepatic recovery. Thank you all.
Any questions from the audience? No? Congratulations, Dr. for your work. Okay, so we finished earlier. The next presenter doesn't show today. So thank you for being here, and I hope to see you in the farewell reception today, or if not, I hope that you enjoy Santiago today. Thank you.